Hi, everyone. I'm Eric Krupa. I'm a supervising attorney with the center. Thank you all for being here today. It's great to be around so many people who care about these issues, are coming at it from different perspectives, different roles. I'm with the Center for Medicare Advocacy again, rejoining earlier this year, and this is my first in-person summit. So in particular, it's really good to be with you all here today. I'd like to take a second to thank the Alzheimer's Association for their support and their mission to end Alzheimer's and other forms of dementia. Our longtime partnership means a lot to the center. And now I'll introduce our panel, Pathways to Advocacy, led by CMA's Kata Kertesz, who's our managing policy attorney. We also have Dr. Ed Weisbart, who serves as National Board Secretary and Missouri Chapter Chair of Physicians for a National Health Program. Unfortunately, Amy Hall can't be with us today. She's Minority Staff Director of the Subcommittee on Health within the Committee on Ways and Means for the U.S. House of Representatives. She understandably has a lot of work to do right now. But graciously filling in is Cathy Hurwit. She served for 20 years as Chief of Staff to Representative Jan Schakowsky, where she's a strong advocate for universal health care and senior and labor issues. She's now a board member for Healthcare for America and CMA, and she's the treasurer of the DNC Seniors Council. So with that, I'll turn it over to Kata. Thank you all again.
Thank you, Eric. As he mentioned, I'm Kata Kertesz, Managing Policy Attorney at the Center for Medicare Advocacy. Welcome to the panel, everyone. We're here to discuss different pathways to advocacy as a means of striving for meaningful pathways to change, achieving substantial improvements to our healthcare system, eliminating harmful barriers to care, improving access to necessary treatment for all beneficiaries, supporting aging with dignity, and bolstering robust quality of life for beneficiaries and their families. Cathy and Ed will discuss how advocates can push for these policy changes that improve lives, including grassroots advocacy, presenting proposals to Hill staff, building coalitions, and spurring momentum behind proposals. Cathy and Ed will address how advocacy strategies must respond to the challenges presented by the environment we're currently inhabiting, including the tax bill that touches on Medicare and Medicaid. But they will also infuse hope into our discussion, relaying the best approaches for coming together as a community, pushing back on harmful changes, while striving for impactful, positive improvements to our healthcare system. And with that, I'll turn it over to Ed.
Hello. I'm Ed Weisbart. I'm a family physician in St. Louis, and I'm the National Board Secretary for Physicians for a National Health Program. And I think I'm here to talk to you about, our organization is about, I would say, 6 years into an intentional transformation from a research and education foundation into a direct advocacy organization. So I want to talk a bit about how we went through that, what we've been driving through that, what the mechanism for that's been, and what this means. I'm hoping that will serve as an example for other organizations that might also want to do that. So we started, as you may know, in 1987, really research and education centric on Medicare for all. As our past president, Phil Verhoff, said recently, when he first heard the organization talking about Medicare for all, his first question was, have you told anybody about this? Because he thought if you heard about this, of course you would want to support it. So we just have to tell people. And that was frankly our strategy for a long time. If you build it, they'll come, crossing one leap across the chasm. And that was the right strategy because nobody really had been talking about it. And then the Sanders campaign happened, and regardless of what you might think of him as a hero as I do, that changed the landscape of what Medicare for All's, how people understood it. And it took us a little bit of time to figure that out, that had happened, but then we embarked upon a very thoughtful, intentional change of our organization with all the things you go through in the first phases of that, a SWOT analysis and all of that stuff. And then about a year after we began that, we thought we're just chomping at the bit to do things, and we started what we called the kitchen table campaign, which was rather than talking just about Medicare for All, we decided, well, let's talk about what people are talking about. What are the healthcare issues that are on their table, and then show them the connection between that and Medicare for All, and all the things you would think, surprise bills, equity, reproductive freedom, a whole suite of these topics that were evidence-based, chosen by evidence of what's on the kitchen table. And there were two key things that we learned from that. The first was we acquired a whole bunch of skills that we didn't have. We developed a skill at making quick videos, long videos, talking points for radio interviews in multiple languages, a whole suite of tools that we developed. So that was great. We still have those skills. And then the second thing we learned was slow down. We were so eager. We had literally 6 campaigns over 6 months. We thought we would build a campaign, we would put it out to our chapters, and they would be so happy with that they would then run off and do all these things for a month, and then change gears to a different topic, and then the second month, so we learned, no, that's not the right approach. But that got us ready for then the next year when we learned about the direct contracting entity thing that President Trump invented. I guess his team invented in 2020 and got, well, we won't do the content on that, but we decided that was a major direct threat on traditional Medicare that nobody seemed to know much about, and Rick Gilfillan actually kind of got us hip to it. And we decided to focus on that. So we made that our focus of advocacy work. I'll explain how that fits in just a moment. And we focused on that. I think we had a significant impact that evolved into ACO REACH campaign work that we've been doing. So that was our focus for quite a while. And then we recognized that actually is only a prelude to what we started talking about a bit today, the Medicare Advantage piece. And we looked at privatization writ large. It's everywhere, of course, it's everywhere, and decided we can't focus everywhere. We decided to focus on Medicare Advantage. That was one of the lessons from our kitchen table campaign is no, you can't focus on everything. Pick the thing that you think is the most important. So we did, and then that led us to where we are today, which is what we sort of capsulized as our triple aim that really organizes how we approach things. So I want to explain what that means. So we still have as our central focus, of course, the thing that we're organized around, single-payer Medicare for all, but we've decided that, Teddy Roosevelt campaigned on national health insurance, and he lost the 1912 election. So we should learn that that's not an adequate strategy. So instead, we've got 3 aims. We're fighting the profiteering and the privatization, and we're trying to use that funding and that's to improve traditional Medicare in the ways that a few people have already mentioned are so desperately important. And by profiteering, we focused specifically on Medicare Advantage. And on improving traditional Medicare, it's the things that you all are intimately aware of. And we believe that campaign, those 2 pieces are instrumental that's the best roadway to moving us forward. But we also realize that there's like a brick wall between here and there. So to cross that brick wall, we decided we needed more power. And we're very specific about that. So we think we need to be bigger. We are now about 26,000, mostly physicians around the country. But there's like 1 million physicians in the country, most of whom agree with us. But we need to be bigger. We need to be more powerful. If we can go to Congress with 100,000 voices, that would be much more effective. So growing our membership is sort of a core of what we're focused on. We needed to have more resources. So we're a group of doctors, so it's absurd that we had to tap that more. And so because of our focusing on tapping our physician membership, we now have more national organizers, which empowers the rest of our plan. But because of some of the work I'm going to show you, that also made us a friendlier group for some of the grants that we're fortunate enough to be able to work with. And Arnold Ventures, hooray for them, and Robert Wood Johnson Foundation. So I'll talk about that a bit. We also decided we needed to have a broader connection to legislators, and so we've been working quite actively on that. And lastly, we're no longer sort of viewing ourselves as the lone voice out there, but we're recognizing we have a very specific role within the advocacy community writ large. We'll come back to each of those pieces. But this broader vision, this triple aim, I want to show it a little different way, has allowed us to reach into groups that we've not been able to reach before. So rather than only talking if you ask us a question about a policy 10 years ago, our answer would be, it's not single payer, so we don't like it. And that's not the way to get people to keep asking you for a point of view. So profiteering is really an important piece of what we want to expose and fight about, and it has opened up all sorts of doors and communication and dialogues with people that are really close allies, even though they don't necessarily agree with our intent that those fundings should be redeployed into improving Medicare. And that's fine. There's a whole lot of common ground on exposing and fighting the profiteering and privatization, even among people who don't agree with us about that second circle. And not everybody who wants to improve traditional Medicare in the ways that we've been talking about, not all of those folks, probably not everybody in this room thinks that that's important because, in part, it's a way to get towards single payer. So that's great. We can talk about this in these broad ways. And the point is that there's a bigger audience that we can work with and we can move into. So we found this strategy to be really, really important. We began the work by thinking, are we just, doctors doing the usual thing, talking about health outcomes and making people healthier? First of all, are we talking about more money or less money? And we were very disturbed by the MedPAC reports showing, 80 or more billion dollars being squandered, but yet members of Congress saying, yeah, it's overpaid, $10 billion on upcoding. Well, MedPAC says like 80, and you're saying 10? We saw a huge disconnect there. And so we decided to focus on that, and then our analysis says that MedPAC is really probably underestimating it. We think it's more like 140 billion because of categories MedPAC doesn't include in their analysis at the end of it. So we started there, giving us the confidence to say this is budget neutral or budget favorable, what we want to do. This isn't, this is a very reasonable, conservative, friendly approach, which we didn't know until we analyzed it. And then that led us to the question of, well, but we are doctors. What's the health impact of Medicare Advantage and profiteering and privatization? And we discovered it's overwhelmingly dangerous. Medicare Advantage isn't just a crazy waste of money, but it's incredibly dangerous. It hurts people, and in our report you'll see compelling evidence, I think, that it actually kills people, that it's completely unacceptable to me. And yet, I see the trade-off. I see the overfunding does provide the extra benefits, so it's not an easy piece, but that's why our triple aim is deal with privatization, but use that money to give people a safe landing pad back in traditional Medicare. So these are integrated things, but we needed to expose the harm. We thought that was all we had to do. We thought, go to Congress, talk about tens of billions of dollars, 80 billion or 140 billion, and it's killing people. Of course you're going to join on board. But the common pushback that we got that we were hearing was, but the disenfranchised communities in our country are seeing Medicare Advantage as a solution or a step forward on that problem. And equity is the main thing that they don't want to hurt. And guess what? We don't either. But they didn't see this argument that it's killing people. I thought that was enough. Anything that kills people is not a solution to equity. That doesn't work that way. That didn't land. So we decided we'd do a deeper dive onto that, and that's what we are about halfway through this report that we're planning to release in September, really looking closely at the impact of Medicare Advantage, specifically on the inequities, specifically on the black population of America. And it's pretty striking what we're learning from this, and I have to really give a shout out of thank you again to Arnold Ventures for funding this report. And remember, Arnold Ventures, spectacular, driving a lot of positive progressive change in the country and enabling. It's great. I can't speak for them, but I don't think that they're really a single payer-centric organization. And yet, this is a great example of the common ground. We have this thing that we're working on in commonality with them, and they funded this report, which we'll be releasing late August, early September. And then we have the joy of another great grant from Robert Wood Johnson Foundation looking at sort of the harm on physicians. It's not burnout. Physicians aren't burnt out from working too much. Physicians worked a lot in the 1950s and 60s and 70s. The problem of physician burnout is actually the moral injury of knowing how you can help somebody and having some greedy organization stepping in between you and saying, not so fast, don't help that person, because it's not profitable, and that's just causing moral injury. So we're going to do a really good academic study on this that we'll be releasing late this year, we hope. So how do we change the organization? Well, we are a physician-centric organization, as you know, so we want to use that asset. So physicians need to hear about science and policy, and so need to help develop that. So that's, of course, a big piece of where we focus. And they have narratives. We have narratives. You know, the stories you just heard about cancer treatment and millions more. But we need to be empowered to raise our voices and tell stories that we can tell. I think that's very helpful. We need to amplify sort of exponentially our power by working through existing organizations, the medical societies that most of us belong to. We need to be raising our voices there. And we have a whole campaign organized around multiple pieces of that. And, you know, doctors went to med school, but we didn't go to poli-sci school. We don't have any idea how to talk to politicians or members of Congress. So we've been doing aggressive campaigns on educating physicians on how to meet with members of Congress. They are now becoming increasingly independent at doing that, so we can train other doctors at it. It's really growing. We're seeing that really grow. We have campaigns on how to learn how to write op-eds and all that happy stuff. Med students are sort of the voice of the future, and we want them to be embedded, activism embedded in their work. I view that sort of like the Federalist Society getting into law schools 50 years ago and not telling anybody that their goal was to reverse Chevron in the Supreme Court. So, you know, we view this as a long-term piece that has immediate and long-term benefits, and frankly, the students I've learned so much from them. They're refreshing our whole point of view. And we have the fortune of chapter organization. We have chapters in almost every state, some more than one. This makes people getting engaged, personal, local. It gives them a chance to build skills, have an impact at their state legislatures in lots of things, and that's a great way for them to build relationships with Congress, too, doing it locally. And then we have national campaigns. Most recently, we did a shadow hearing exposing what we view as some of the concerns about Dr. Oz, and we've done other things of that sort that then people around the country build. But we really do see our role as one of many within this coalescence of organizations, and I hope I didn't leave anybody off of that, but most of us are meeting like literally every 2 weeks for the last 2 years, coordinating our work. Oh, you've got this, let me amplify that work you're doing. Oh, we've got this, can you amplify that? Here's tools we built. Oh, I like your tools. Oh, that's great. So we are actually really working together, and there's only so much more. There's so much more in the near future that we're just really excited about. So, hooray.
Thank you, Ed. Cathy?
Well, again, I'm sorry I'm not Amy Hall. I'm sure you would rather hear from her than from me. But what I want to do is give you a kind of my general sense of advocacy and then talk specifically about the reconciliation process, which is going on right now and will be going on for a while, and in terms of Medicaid. So in terms of advocacy, having been on both sides, I worked for Citizen Action at AFSCME, and I worked on the Hill for 3 different members of Congress. I think the most important thing is to know what you want and what you don't want, very specifically. Then you've got to know who can give it to you. We don't need 435 members of the House to vote with us. We need 218, normally. We don't need 100 senators, we need either 51 or 60. And so you need to target that. And then you need to be able to explain to the target that you have, the person you're trying to persuade to do what you want, why they should care about you. Maybe you have the expertise they need, you represent an important group of people or institution in their district. You may be thinking about running against them, I don't know. But you've got to be able to think about what your power is in terms of the person you're trying to persuade. So let me talk very quickly about Medicaid. You heard from everyone this morning why anybody who cares about Medicare should care about Medicaid. Let me add that the structure, when we hear about nursing homes closing, we hear about hospitals closing, particularly in rural areas. The people who suffer are not just people on Medicaid, it's everybody. So we've got to think about that. The importance of Medicaid in a recession is really important, and I'm not an economist, so I can't tell you, but there's some who say we may be heading there. That's really important. And when we think about, there's seniors over there, young people over here, kids over there. People live in families. And when people are hurting from a recession, they may not be able to help their grandparents or their parents. So we need to think about that. And just to be a little bit philosophical here, the idea that some people don't deserve health care, the idea that we should take health care away from people in order to fund tax cuts for billionaires or to reduce the deficit, when we let them get away with that, that sets the precedent for Medicare fights down the road. So I think we can't let them do that. So Medicaid. The idea about providing information to members of Congress and their staffs on Medicaid in terms of this reconciliation bill cannot be overstressed. I mean, think about this. The Energy and Commerce Committee, which is debating this right now, 17 members were not on that committee last year. That means they may have no expertise in Medicaid, and we know how complicated Medicaid is, right? They have no expertise. There was not a hearing held on the proposal. The bill came out Sunday night. They started marking it up Tuesday. You know that there are things in that bill that nobody knows about. We're all going to find that out, and we're going to be able to educate people about it. Advocating for no cuts. This waste, fraud, and abuse, and I was talking to Toby, we worked so hard on the nursing home safe staffing standards for years and years and years. That's labeled waste. I mean, literally, they say waste, we're going to get rid of that. We cannot let them define waste, fraud, and abuse as taking health care and services away. And it's not just, as you heard this morning, it's not just a question of people losing total coverage. It's a question of people losing the benefits that they get, because if they're on Medicare, they get benefits through Medicaid that they wouldn't otherwise get. So we can't let them get away with that. We can say, if you want to get rid of waste, fraud, and abuse, let's talk about getting rid of Medicare Advantage upcoding and lowering prescription drug price. So we can define those terms ourselves. And I think, as Ed was talking about, we have a very, very broad coalition. It's not just that the public polling is supportive of Medicaid and thinks government should be doing more to get people affordable health care and comprehensive health care, but we have a very big group of people who are concerned about this specific bill. And here's where the hope comes in, okay? First of all, remember what happened when Trump first came in the last time. And everybody said, the ACA is done for. It wasn't done for because we all organized and we all did it. Prescription drug, you heard Chiquita talk about the Medicare price negotiation. They said it couldn't be done, and we did it. We can stop reconciliation. This is just what's going on this week with all the committees marking up, and they're doing horrible things on SNAP and other things. It's just the first step. They're going to package all this. They're going to take it to the House floor probably next week, and then it goes to the Senate, where Josh Hawley has already said he's not voting for Medicaid cuts. And Ron Johnson, Sarah showed me, Ron Johnson said this bill's going to be dead in the Senate. It's going to be dead if we all get together and fight on this and make our voices known and let people know what's really in this bill and how really bad it is. And I'm going to talk about, Ed talked a lot about the coalitions, doctors, hospitals, nursing homes, there are a lot of people who we don't normally work with, but one group of people we haven't talked about are state and local elected officials. Because what this reconciliation bill does is it shifts costs to them for Medicaid, for SNAP, for other things. They have balanced budget requirements. They shouldn't, but they do, which means that they're going to have to cut people. And again, going back to if we're heading into a recession, it's particularly the worst time. So I actually think this is our and the other thing is our power has already been seen by the fact that the Republicans don't want to say they're cutting Medicaid, right? So, we should feel emboldened and we should feel energized and looking at the impacts if we don't win, we should feel as committed as ever to fighting this fight, and I think we can win it. So thank you.
Matt, do we have questions online or Jeff in the room for our panelists here?
Oh, one second, your mic's not on,
We can't
Matt.
hear you, Matt.
Hello?
Yes.
Haha.
Okay.
Heard a couple words on this panel like equity and science that made me wonder how advocacy approaches have changed or maybe should change in order to respond to the current environment.
Both of you can. Go ahead.
My approach is double down on it. I'm sorry, equity is not a nice to have. It's a must have. We have to deal with these problems. Science. I won't even go there. I don't think there's any backing away. I think there's popular support for these things in general, actually, and I think that's just all the more reason for us to make the case and be more compelling and to escalate our use of these notions.
I'm not sure I actually understand the gist of the question, but I do think what is really important in healthcare is to be able to, at the same time, lift everybody up and recognizing that there are people who are not getting the health care that some of us get, but making sure that the solutions are universal so that everybody feels that they're going to be protected.
Any questions in the room for our panelists?
Yes, anyone have any questions in the room? Anyone? Matt, I can pass it back to you at this time.
I have one as a moderator. I'll take this opportunity. Can you both speak to the strategic benefits and challenges of embracing incremental change in policies upon which additional expansions can later be built versus larger, more comprehensive changes? Cathy, we can start with you.
All of a sudden I remember that one of the founders of PNHP, Dr. Quentin Young, used to say you can't leap a chasm in 2 leaps. You have to do it from here to there. And I would like to agree with that, but having worked on the Hill for almost 40 years, I think we need to take steps. I think that prescription drug negotiation, one of them, I am a particular fan of doing all payer rates because I think that gets rid of a lot of middlemen and it gets a lot of equity and it takes away some of the discrimination in healthcare. I think we have to look. I remember when we passed the ACA and people said it wasn't good enough. And they thought that people like Dennis Kucinich would vote against it because it wasn't good enough. And the members sat around and they said, it makes a real difference to people. Passing this bill will improve people's lives, and we've got to do it. So if it's an incremental thing that moves people's health care in a better place, I think we should do it.
Yeah, you're right. That used to be sort of our organizational mantra. You can't cross a chasm in 2 leaps. But I don't know about y'all. I've been to the Grand Canyon. People that have tried to jump across, there's a lot of dead people down there. It's not how you cross a chasm, in my personal point of view. You get a rope to go across, and then you pull a bigger rope, and then you get a bridge. The point is, though, the rope has to go across the chasm. You have to actually be, direction matters. You have to be going in the right direction. So Medicare was incremental.
And can I just say that, incremental is not a dirty word. I mean, things like Medicaid expansion may be incremental, but it sure made a difference to millions of Americans.
Well, go back before Medicaid expansion. Medicare and Medicaid are not universal health care. They leave out most Americans. So, you know, those are incremental changes. Should we, let's repeal Medicare because it's too incremental?
Yeah.
You know, no, but the key is we have to be thoughtful about what those changes are, and we can walk and chew gum. We need to simultaneously be tracking where we want to go. We know, you know, just last week, the reintroduction of the Medicare for All bills was introduced with more than 100 people in the House and the largest number I think we've ever had in the Senate. So we need to keep those bills alive. We need to keep on moving that forward. But that's not the only thing we should be doing. You know, we need to be. There's lots of other stuff. So I think we can walk and chew gum at the same time.
Great. Jeff, how are we doing on time? Okay, we have a question, and one over here as well.
One question in the room. Here you go, Tatiana.
Thank you. I represent all the millions of people in California. Two things, and I think this is directed to the medical community. Last year, scripts dropped out of all Medicare Advantage plans, and it left over 35,000 beneficiaries who were in Medicare Advantage to scurry to look for a new plan or go revert back to original Medicare and find a provider that had open practice, number one. And number two, they had no guarantee issued to get a Medigap because of that situation. So now it shifts to the policy because there is no special election period when a major medical group pulls out. So do you see any will to add more special election periods? Because, you know, I'm an educator for the California High Caps SHIP, and it's a really difficult question that we have to answer to our beneficiaries.
I mean, philosophically, I think if Medicare Advantage beneficiaries are being demonstrably harmed by some of the policies that have driven provider groups out, I think that just, I'm not an expert on this question, but I would support a thing that would say, yeah, you know, you should be protected against that harm. But more specifics I can't. Do you have?
But if you look at the reconciliation bill that's being debated right now, they're taking away special enrollment periods. So I think again, this is the difference of philosophy is that, you know, one side wants to make sure that people when have access to health care that's meaningful access, not a piece of paper, but there's no place they can go. And the other is trying to save money by restricting whether people can do that.
If I could make one more point on this, I thought where you were going to go was should there be protections in Medigap so that you do have guaranteed issue and community rating if you decide to go back. And I used to think that, but then I looked at the 4 states that have that, and as you could predict, they have higher Medigap premiums because, you know, adverse selection. So if you did that as a policy, you would expect premiums in Medigap for everybody to go up, which is the nature of insurance. Mm-hmm. And they also have higher Medicare Advantage penetration growing more rapidly because people are less afraid to join Medicare Advantage when they know they can get out. So a policy of supporting guaranteed issue and community rating around the country for Medigap would adversely raise premiums and actually accelerate Medicare Advantage adoption. So I would not support that as a direction.
I think we're out of time for our panel. I'm sorry for all the questions we couldn't get to right now. I think we're going to head into our break right now and return.
We will return at 1:50.
1:50.
So about a 12-minute break, everyone.
Okay,
Thank you so
please
much,
join
panelists.
me in thanking them.